Hi everyone, good afternoon. This is Olivia Henze from the New England QIN-QIO. Thanks for joining us for today's webinar, an overview of the Interact program with Carol Deese, Sheila Eckenrode, and Florence Johnson. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines are on mute for the duration of the presentation. As I said before, if you want to manually put yourself on mute as well, that would be great. Sometimes we'll get a little background noise that comes through. It shouldn't be an issue, but if you can manually put yourself on mute, we would appreciate it. And we'll take questions at the end, and I'll provide you instructions on how you can unmute your line or pose a question in the chat box. I'm now going to pass it over to Carol to begin. Carol?
Good afternoon, everyone. Welcome to the first of the 9 webinars on the Interact Quality Improvement Program for nursing homes. This is our 3rd year presenting this important work. I am Carol Deese, as Olivia mentioned, and I'm one of the Quality Improvement Consultants for the New England QIN-QIO, the Connecticut office. And I am here with Sheila Eckenrode, our Care Transition State Lead, and Florence Johnson, who was our Nursing Home State Lead, as well as our Certified Interact Instructor. Sorry about that. I'm all excited. Each of us will be with you each step of this journey, and please know that if you're going to do this quality improvement program right, it will take your facility up to the full year to embed this into your culture of safety. And that's what Interact is all about. It's about making your nursing home safer for your residents. The last thing I want to highlight is that please know Sheila, Florence, and I are here to help you throughout this implementation of Interact. Please don't struggle alone. Give us a call so we can help you earlier on rather than later. Our contact information will be on the last slide of every session, so make sure you reach out if you need us. So today's session, the objectives of today is we are welcome each and every one of you in joining us in this important work. Also, the participants are going to have a better understanding of the readmission rate root causes, also the goals and objectives of what Interact is all about. Also, we're going to be describing the Interact and how to describe Interact to leaders and also your colleagues, and also understanding the importance of forming an Interact team. Without a team, the work is going to be very hard, and it may not get done. So please know, and that's why Sheila's going to be spending some time with you today on what is an Interact team and what's the role of each of the members. And then Florence is going to navigate the Interact site with us today. Again, this is just an overview, but it's important to know that the Interact site is open to all, and Florence is going to highlight what the different areas of the site. And then we're also going to talk about our sharing session. After each training, the last 15 minutes is all about sharing with other nursing homes any challenges that you had for the month, or any of the success stories. And that, we have found, is one of the most important 15 homework time, but it's really sharing time. And as Olivia mentioned, as we are presenting today, please, if you have a question, put it into chat. So we'll have it right up there when we open up the lines, and we'll start off with that. So without further ado, I am going to pass the slide over to Sheila Eckenrode to start talking about Interact.
Welcome, Interact pioneers. We're very happy that you're here. Our goal here in the state of Connecticut is to become the first state that has full Interact implementation in extended care facilities. We promote this as a goal because we know that this is evidence-based best practice, that it does indeed work, and that here in Connecticut we're known to be innovators and early adapters of good practice. So we're happy you're here. Thank you for participating, and thank you for making patient quality care your primary goal. So a little bit about Interact. Interact was designed to address some of the root causes of readmissions. We know that 30-day unplanned readmissions result from failure of communication at handover, inadequate patient information at transfer, a failure in compliance without applicable, of course, to long-term care, poor understanding of diagnosis and outpatient care treatment plans, and the failure to note early changes in condition of patients and residents. And that's something that Interact is very, very good at helping long-term care providers improve in. Okay. So when we talk about the root causes that Interact is going to address, we're going to talk about improved communication, improved handovers, improved compliance with outpatient care across the continuum, and absolutely early identification and changes in resident condition. I just want to tell you a little bit about who we are, because you're going to get emails from us all the time, and before you delete them, you know us as Qualidigm, but we're actually part of the New England QIN-QIO. The QIOs were state-based for many, many years. We contract with CMS. We work to implement the National Quality Strategy. Yes, there is one, and it's still there, even with the change of government. We still have a National Quality Strategy. And part of that strategy is to reduce 30-day unplanned readmissions. Some of the other that you're most likely involved in is improving care for long-term residents by decreasing antipsychotic use, decreasing pressure ulcers and falls. Some of you work with Florence on those initiatives. In addition, we talk about reducing healthcare-required infections and improving acute care. So those are all parts of the National Quality Strategy that Qualidigm, as a member of the New England QIN-QIO, works to help providers in Connecticut achieve. So we are part of that. Rhode Island is our administrating QIO. You'll hear us talk about our 6 New England states. There they are. New Hampshire and Vermont, which is actually New Hampshire upside down. And now you have a map of it all, so you can plan your summer road trips. The idea behind forming regional QIN-QIOs is to share best practices, to share resources, much like when individual long-term care facilities align with a corporate parent. Suddenly you have more resources to draw on, you have more ideas, you have a bigger bank of brain power. So that's what we were hoping to achieve, and hopefully will continue to achieve. So for this collaborative, for this piece of the QIN-QIO work, we're looking to reduce 30-day unplanned hospital readmissions across the state by 20% from baseline by 2019. So let's look a little bit at where Connecticut is at the moment. And we only have data up to calendar Q3 of 2016. That's because we get our data from CMS claims, and it lags quite a bit behind. But just to give you an idea, we're trending down in 30-day unplanned readmissions ever so slowly from SNS. Enough data points under the median to say that there has been a change and it's going in the right direction. So currently, and this also parallels our Interact journey. We began implementing Interact across the state, although we had some early adapters who had taken this journey before Qualidigm took it on. But we really, went for it around Q1 of 2015. So we're slowly moving in the right direction, and it's a good thing. But that only tells part of the story. The readmissions are part of the story. The rest of the story is improved communication between acute care and long-term care, improved quality of care and continuity of care, and improved patient safety, measured in a different way. All right, so I would ask, where do you stand against that state average of 19.3%? And how would you know where you stood? So this is our first polling question. Does your facility collect monthly data on readmission rates? And Olivia's going to tell you how to answer.
Looks like Emily just opened up our polling question, so you have 30 seconds to answer. Please make sure that after you answer, you press the submit button at the bottom. Again, make sure you press submit after you've answered the question. It looks like the poll has ended. However, if not everyone has pressed submit, unfortunately it takes another 30 seconds for the answers to come through, so they should be coming through momentarily.
I guess I could start singing if you'd like.
There it is.
Okay. So does your facility collect data monthly? Yes. 19 out of 39. No. 1 out of 39. And no answer is 19 out of 39. Okay.
All right, that's where we stand in this group today. By the end of this 9 months, everyone will be collecting data monthly and looking at it and being able to quote it and say where they are against state and the national benchmarks. So thank you. Thank you for participating in the poll. Florence is going to give us an introduction on what Interact is. Okay, Florence.
Good afternoon, everyone. As my colleagues have said, thank you so much for joining us to talk about Interact today. Interact is an acronym that stands for Interventions to Reduce Acute Care Transfers. It's a quality improvement program, as Carol stated. It really focuses on the management of acute care changes in resident conditions. So, Interact was originally designed to improve not only the early identification, but also looking at assessments early, how you document, communicating the changes of residents within your facility. What we want to do with Interact is that we want to catch early nuances that occur. We have to transfer our residents. And when I talk about this, I always like to liken it to when you have a child, a newborn or a toddler. You know your child. You know when they're not feeling well before it even gets to the point of a fever or pain. So you start to feel as if there's something going on. So this is what we want to catch. We want you to catch that unspoken change in condition early enough to start to intervene. Interact was first designed in a project that was supported by CMS, and it was looking at skilled nursing facilities in the Georgia area with high readmission rates. So they got a grant, and they looked at what was going on in all the buildings, and they developed a tool, and when they piloted the tools, the facilities that stayed in the pilot throughout the full year actually only used 2 tools. And with those 2 tools, they were able to reduce their readmission rates by 50%. So we're hoping that as a state, we can do so much better than that if we're able to implement all of the tools within Interact. So the goal of Interact is to improve care. It's not transfers. When I first started teaching Interact, I was getting so much pushback that Qualidine is trying to keep people from going to the hospital, and that's absolutely not the case. We're saying that there's some situations that you should be able to handle in your building if you catch them early enough. But in the event that you have to do a transfer, by using the tools within Interact, your transfers should be more seamless, and the receiving acute care facility information that they need to provide care to your residents. So unnecessary transfers cost CMS, the government, you and I, billions and billions of dollars every year. So we need to look at what we're doing, and we have to start doing things a bit differently. Besides the money factor, we are taking care of the most fragile people in our community, and we send them to the hospital without enough information. They are unable to speak for themselves, and they're at the mercy of the care provider at the hospital. So think about that next time that you're sending your resident out. So I have a polling question for you. Anyone on the call now, is your facility using any Interact tool? Again, answer yes or no, and then hit submit so we can get you into the count. And no, Carol, we're not going to have you singing. Just throwing my heads up. All right, so if you're concerned about it, you know this is anonymous, and it's all just to get a baseline of where we're at this point. Because we would like to see growth by the end of the 9 months. Okay, while we're waiting for that to, go ahead, stop. Yeah.
We have to probably wait
seconds.
after more time. If not everyone presses submit, then
It takes a minute.
Literally, it takes
And I'll take a breath because I know I talk fast.
there you go.
There it is.
You're up.
So 29 people out of 47 are using some tools. That's awesome.
Absolutely.
All right, and only 4 are not using anything. I know the other 14 you just forgot to press submit, so you're okay. Okay, so as part of the Interact program, there is a checklist. It really helps you to look at where are you now. So for those of you who have said you're using some type of tool, you can use this checklist to look at all the different tools that are within the program to say, okay, yes, we're using it. You can even look at it to say, are we fully using it? Is it that one unit is using it, but another unit is not? So when your facility says we've implemented it, I'm hoping that that means that everyone in the facility is using it and using it all the time. It also gives you an opportunity to look at where you're not using it to provide education to your medical staff, your staffing, and look at, the degree to which you are using the tools that you're not using. Please remember that Interact is more than just the S-bar or the stop and watch or the red envelope. Because when I talk to people and they say, oh, yes, we're doing Interact, and I ask them, oh, we're doing the red envelope. That's great. But there's more aspects to Interact than that, and you'll learn that as we go along. There are 4 major components of Interact. There's the quality improvement tool, there's the communication tool, the decision support tools, and the advanced care planning tool. Now, each tool is set up for select members of your care team. However, for Interact to be fully successful, all members of your care team should be aware of all the tools and should be aware of the fact that you are using Interact in your building. So at this time, I'd like to take you onto the website. The web address is interact2.net.
Nope. You have to. Okay. Pardon us for a minute.
Okay.
Let's go to share. Okay, so you should.
Yes.
Perfect.
All right. So this is the website. After you've dialed in and typed in interact2.net, it will bring you to the home page here. So when you first sign on, you'll get two options. There's a green button that says I accept, and you have to push that button to enter into this landing page. You're not buying anything. You're not giving anything away. All you're saying is that you agree that the intellectual properties of Interact belong. Make copies of their tools and put your facility name or title on it. It's their tool, and you must use it the way that it was built. If you change any part of it, then you cannot say that you're practicing or using Interact. So once you're in there, you want to go into Interact Tools. Oh, here it is. I agree. So then you go into version 4.0. When I first got trained, I think we were just at Interact. And then every year they've improved it based on how people are using it and the feedback that they've gotten from the test sites. So this is an algorithm that shows you how Interact intercedes with what you're doing every day. So you have a resident that gets admitted or readmitted. You need to be talking about their care, advanced care planning. We all know that during emergent times is not when you should start talking about DNR status and do you want IVs or no IVs. You should be doing a med reconciliation worksheet. You can either use what Interact has, or if you have your own, that's fine, but MedRec should be happening upon entry. And then the resident goes on about their business, they have a change in condition. Or the ancillary staff picks up on it, they fill out a stop and watch tool, they give it to the nurse, and then the process just begins. You can just see how it intercedes with what you're doing every day.
You want to go back to the PowerPoint?
Okay. So, I'm just going to quickly go into the quality improvement tools. This is the area where you have your hospital tracking tool, and we will talk about that on an upcoming session, so I'm not really going to go into that. And then you have your quality improvement review tool. This is where you look at your transfers and talk about how did it go, should we have done anything differently. If you belong to a communities of care, this is what they use to do chart reviews and case reviews. And then there's communication within your facility. This is where you have your stop and watch, which was initially designed for just CNAs, and then later on they learned that it was actually useful for ancillary staff, family members, anyone that's not licensed. And of course, everyone clinically knows about the S tool. Again, I'm not going to go through all of these in depth because we will be discussing these later. And then there's the tools that you use for people outside of your facility. Your nursing home capabilities list. It basically tells the hospital what you can do in your facility. We have the nursing home transfer form, which we will be using in the place of W-10s in the future, and we'll talk about that in the future. There's the checklist for the red envelope. This is just tells you what you have in the envelope to make sure that you have everything. And we have the care paths. These are really great for new nurses, nurses who have been out of practice for a while and they're coming back into the healthcare arena. So Interact took the 9 most popular diagnoses and they built care paths for these. And it just kind of guides the nurse at the time, asking these questions, and based on what your answers are, it guides you on what you should do next. And we'll talk about those more later too. So yeah, we have falls, we have UTIs, lower respiratory, CHF, shortness of breath, so your common diagnoses. And then you have the advanced care planning section. This one talks about just having the discussion about end of life. There's comfort care orders. It's already built for you. It's a matter of just discussing it with your medical staff and having them sign off on it, and then you can just put it into your resident's treatment plan. There's discussion about CPR, and it's written with the layperson in mind. It talks about exactly what CPR is, what some of the problems that they could experience. We throw those letters out to people, and we expect them to understand exactly what we're talking about. There's the tube feeding section that talks about what your choices are and how, honestly, tube feedings aren't that great. What can happen after you get a tube feed placed and how you're even at more risk for aspiration. And that's really about it for the website. I don't want to go into it much deeper than that. Please, after the webinar, take some time to go into the website and just play around and see what areas you think your facility could be for. I will now give it to Sarah.
Great. Thank you so much, Florence. That was a great review. And again, that's one of the action items the Interact team is hoping that you've heard. We would like you and your team to go into the website and look around and start pulling down some of the forms just to look at them, because each month we are going to review one or two of the tools. We're also going to be giving you some quality improvement education within a 45-minute period, and then the last 15 minutes is that sharing part of our webinar. So speaking of the sharing part of the webinar, we call it the homework 15 minutes, but as I mentioned, it's really sharing. It's my responsibility to ensure that the homework that is assigned each month addresses implementing the tool or tools that have been discussed, which will help your team move the work into your facility. And that's really, we want to make it as easy as possible for you in steps, incremental steps, so then you can get the work done. So starting next month, the last 15 minutes of the call, we will review the homework from the month before, and yes, you're getting homework this month. Sheila will be sharing that information with you. Here is to talk about any successes or barriers that were encountered during the past month. So it's a true sharing session, peer-to-peer. I just want to mention that if people don't volunteer, Florence has been known to call out a few people who are participating on the call, on the webinar. So it's best to be prepared before the call and then to go ahead and volunteer so you're not being called out. Just saying. Okay, also each month, your facility should be talking about the work you're doing during your community meeting if you are actually part of a community. Just so everyone in your community knows that you are implementing Interact, that this is going to be part of your culture, and that within the next year you can truly call yourself an Interact home. And finally, you need to make sure that your facility is submitting their readmission data into Advancing Excellence. So, with that being said, I want to go over the requirements to receive a participation certificate. And that's what it is. At the end of 9 months, you will receive our certificate of participation from the New England QIN-QIO. The first thing that has to happen is the Connecticut, which we are known as Qualidigm, we have to receive a participation agreement form from your facility, which will allow us to track your progress through this whole 9 months. This has to be into us by April 15th. So write that down, deadline, April 15th, if your facility hasn't submitted a participation agreement form yet. Now, just want to let you know, as part of the registration, it was attached to the registration. If you did not see one, if you don't know, first, you got to ask your nursing administrator, because that's facility administrator, that's who has to sign it. So, and if they did not sign it, if you have not seen it, send any one of us, myself, Sheila, or Florence, an email saying, please send us the form. Because that has to be in place before any of this other work is being done or being tracked. All right, so let's say you sign the participation agreement. Your facility has signed it. The next requirement is that your facility has to participate in minimum of 7 out of the 9 webinars. Minimum 7 out of the 9. Now, just to let you know, every webinar is being recorded. Both the slides and the recordings are going to be QIN-QIO website between 5 to 8 business days after the webinar has taken place. You can log in and listen. If you've missed one, you can log in and listen to it, and we'll track you that way. However, I just want to put this out there. You can only attend 2 by listening to a recorded webinar. You need to have participated in at least 5 live webinars, because that's how you truly learn, because you are sharing with each other. You're going to hear some really great sharing at the end of each call, and we will also talk about what we've heard over the past month, so we're also sharing the work that we've heard about. So 5 have to be live, 2 can be listened to as recorded webinars, but the minimum is 7 out of 9 webinars that you are to participate in. Another requirement is that you have to submit at least 4 months worth of readmission data into Advancing Excellence. Now, Florence is going to have the creator of the tool on next month, if I'm not mistaken, in April. So we're going to have a whole webinar on this tool, and it's called the Safely Reducing Hospitalization Tracking Tool. So you want to make sure, you want to highlight that you attend this so you can hear from the expert of the experts of how to submit data, tricks of the trade, so it's going to be a great webinar. And we're not done yet with requirements. Finally, at the end of the 9 webinars, we will be sending out the Interact Implementation Checklist, which Florence talked about earlier today, but this is what it looks like. We send this out to your nursing home administrator, the one who signed the how many tools have you implemented? And again, we're talking about house-wide. We are not talking 1 unit here and 1 unit there. And this allows us to verify the degree to which the Interact QI program has been implemented. I'm going to be repeating these requirements on a regular basis, so if you didn't get it the first time, you'll be hearing it over again, because that's one of the things that the feedback we've gotten, people have forgotten about the requirements. So in each session, we will make sure we go over that. Absolutely.
So Carol said it's important that you attend them live because you have that month to implement. So we talk about it today. We give you pointers on how to implement it. It's very difficult to watch 2 or 3 webinars and still be able to implement it like you're supposed to. So that's why the requirement.
Excellent. Thanks, Florence. Okay, with that being said, I am going to turn this back over to Sheila, who's going to be talking about building an Interact team.
Thank you, Carol. So, first step is to develop an Interact team, and I can almost hear the collective sigh across the state of Connecticut. One more team, one more meeting. But trust us, this is one thing. You can stand as administrator, as a nurse supervisor, as a clinician and say, everyone must do this, and we can guarantee it won't get done. This is a project that involves culture change, deep process change, You need people in your facility from all levels participating in the implementation of this change for two reasons. You need people to come back to the team, to the group, and tell them what's working and what's not working. And you also need missionaries. You need people out there kind of talking it up who believe in it. So the team must be multidisciplinary in the truest sense, meaning nursing, housekeeping, dietary, social work, administrators, people at the top, people in the middle, people at the bottom of your pay scales. As much diversity as you can put into this team, that would be great. If you have an existing team that looks like that or has a core, you might consider adding to that. Sometimes that makes it a little easier to get this thing up and going. So if you've got a falls committee or any kind of committee that looks at data on a regular basis, and you can add some line staff to that committee, that might be a design that works for your facility. But line staff is essential. You're going to meet monthly at the least, and embedded in our Interact webinar series, you're going to have homework that's actually performed by the team. So the team will be reviewing tools. They'll be doing some root cause analysis work, looking at unplanned readmissions, trying to figure out what happened. And, you know, in doing that and working that way, hopefully the team will become cohesive and productive. That's usually how it happens. You might not have had experience in creating team norms, but I would encourage you to do so. Team norms are just a set of ground rules that when you begin this work, looking at readmissions and looking at process and culture change, you begin by saying to that group at the first meeting, what do we do here? How are we going to be? So you have one person kind of writing down sort of brainstorming approach, what people are saying. Okay, we're going to turn off our cell phones. We're going to try to make it to every meeting. We're going to let people finish talking. We're going to leave our titles and egos at the door and really focus on the problem. Hear what people have to say, what they think will work. And from that, you can kind of sculpt a rule book, if you will, for your team. That's helpful that in as much as nobody really has to be the enforcer, because now you have a set of ground rules, almost like a policy you can refer back to. So if you have a doc on your team who only stays for 2 minutes, you can go back to him and say, well, don't you remember when we began this work, one of the rules that we agreed on is that we stay for the whole hour. So I'd encourage you to think about that. At every team meeting, you're going to want to review data because that's what you're doing. Data is essential to this initiative. You know, you've got some parameters. You want to know where you started. You're going to be reviewing data on readmissions, but also, you know, talk about implementation. How many units, the tools, how many S-bars did you see in the chart, if anyone's reviewing the chart? How many stop and watches came in on the pilot unit? Just constantly taking the temperature. How deep is the implementation? How robust is it? How quickly is it moving along? So you're going to want to do that at every team meeting. And report out. Have someone report out what happened in that team to their peers, at staff meetings, at med exec. Make sure you let those folks know what's going on. At your quarterly meetings, if you've got a board, whatever meeting, this should become a standing agenda item on any regularly scheduled meeting you have, and report out on how Interact is going. So again, team basics. It's got to be multidisciplinary, truly it does. I would encourage you to think about team norms and ground rules, forming them at the first team session. If you need help with that, if that's something new to you or something you haven't tried before, please feel free to call us. We'll help you with that. And I would very much encourage you to assign roles, even if that's not how you usually do it in your facility. This is a good place to try with that too. So who leads the team? The leader's responsibility is to put together an agenda to make sure that whatever we've talked about at the Interact webinar for that month has been communicated to the team, that they know what they're going to be asked to do in that meeting, the leader gets the room together, makes sure the invites go out, that type of thing. The leader doesn't get to make all the decisions. Sorry. Nobody gets to do that because it's a team. But the leader organizes the group and makes it easier for them to meet and get the work done. If you've never used a facilitator in a team before, I would encourage you to think about that. And again, this is something, if you want to try something new and want to call us, we'd be happy to help walk you through that. A facilitator's job is to look at the process in a group, and it can be a very interesting job, and some people, I'm thinking especially social workers, could be very inclined to this type of work. A facilitator kind of sits back and looks at the team and looks at who's talking and who isn't. So before the end of the meeting, they might call out the shy housekeeper who's never been to one of these before and say, you know what, Fred, we didn't hear from you. Is there something you have to say? The facilitator's looking at who's talking and trying to balance participation so that one discipline isn't overrepresented, which if you've been in teams, you've seen this happen. If the docs are in there, it's all about the docs. Maybe it's all about the nurses, but a facilitator is just kind of watching who's talking to who. They're the people who are really good at cocktail parties, and if you ask for a volunteer, I guarantee someone will step forward and be good at it, because people who are good at this like to do it. A timekeeper, so you don't run over. That's good too. That's the person who, if the conversation is lively, and I hope it is, and I hope people want to stay till the last minute, but somebody who's going to say, okay, we only have 10 minutes, we only have 15 minutes, working through the agenda. If you have an agenda for an hour and one topic is 15 minutes, trying to move people along. And speaking of agenda in minutes, someone's got to do that, or all will be lost. I don't know how it works in your facility, but here at Qualiban, the same thing again the next week or the week after that, and then it's like Groundhog Day. So you really want someone to capture those ideas, or else you really feel like you're spinning your wheels. And, speaking of spinning your wheels, there's nothing more disheartening for a team than to feel that they've generated some good ideas, they've made some decisions, and they didn't happen. So that's where we really need that report out and commitment from leadership. So you want to constantly be, disseminating the information. What meetings, MedExec, absolutely a really sort of enlivening thing for a team is to have maybe 2 or 3 people from the team go to MedExec, maybe someone who's never been there before, CNA, staff nurse, housekeeper, whatever, present, where they are with Interact implementation, really jazz it up. Consider some posters and visual aids, make it sort of a campaign. Stories are great. If a CNA on one unit fills out a stop and watch and, saves someone who was going into acute CHF from going to the hospital and the APRN came in and treated in place, tell that story. Let that person tell their story of how they recognize that subtle change. Those stories are really powerful, and we hear them all the time in the field. The CNA who says, well, every Monday when I come in, Jose has asked me about my son's baseball game, and this Monday he just forgot, and it wasn't him. Or Alice always eats 3 desserts, and for lunch she only had 1. They're really in those rooms, sort of housekeeping, and they really get to know folks. So those stories are powerful. Report readmission rates, post them, with the caveat that you tell people why this is important. As Florence said, don't be surprised if your staff doesn't react with, oh, well, this is just medication. How much more complicated it is than that. Hospitals are not good places for the frail elderly. We know that in hospitals, nursing home patients develop pressure ulcers waiting in the ER. Think about that, because they've been in the same position for that 17-hour wait to see a doctor. If you send your residents to the hospital and they're ambulating, chances are when they come back, they're not. And it's disheartening for the families, it's disruptive to the patients. So, and we got the goods. You know, in long-term care, we've got the goods. Nursing homes aren't staffed anymore by people who don't know how to treat illness. You know, you've got some really brilliant nurses, APRNs, astute aides, so we can do this. We can take care of people in their home, which is the place they live, which is your facility. And also you want to report out on Interact implementation. As I said, the number of times tools are used, who seems to be doing it well, who seems to have that religion on it. So that's it. I'm going to open this up for some questions at this point. Olivia's going to unmute the line.
We can take a few questions. If you'd like to ask a question over the phone, we will keep the lines muted. Usually you can press #6 to unmute your line. Again, that's #6, or you can pose a question in the chat box. Just make sure you're sending it to all participants. Looks like we have a question.
Hello?
Hello.
My name is Josie, and I'm calling from Jesus Center, and I just wondered if we don't sign up by April, are we still able to incorporate the Interact tool?
Of course. Of course you can implement Interact whenever you'd like. However, many of the hospitals have preferred providers. I'm sorry. So they are looking, the preferred providers, they are looking for their preferred providers to have this Interact participation certificate. So that's why this work it's all about patient care, but we're also looking at how we can help you making sure that the work that you're doing is evidence-based best practice, and that's what hospitals are looking for. Florence, do you have something to add?
Just make sure you get your participation agreements in by April if you're looking for a certificate. You can always jump on the calls. If you're a building that's already gone through this, but if you have a new staff member or you missed a few sessions last time and you just want to catch. If you're part of a preferred provider or ACO and they want you to use Interact, you have to get your participation agreement.
Okay. Thank you.
You're welcome. Are there any other questions?
Again, #6 to unmute your line, or you can pose a question in chat.
And that was a great question. Thank you.
Hi, I wanted to know if it's possible to print out. Hello?
Hello? Yeah, we heard you, but you just got cut off. So print out what?
The slides from this presentation.
Yes, so if you did register for the webinar, you should have received an email today that had instructions on how to log in, as well as a link to the event webpage where our presentation is currently. We will be sending a thank you email out again to all registrants with that link. I can provide it in the chat box right now as well.
Okay, thank you.
Yep, and the link is to the New England QIN-QIO website. So that's where that link is going to be going to.
Yeah, and I'll put it in the chat box right now. But again, you will receive that information in the thank you email.
Okay, thank you.
Any other questions?
We're not done yet. Sheila has one more slide to go, so hopefully nobody's jumping off just yet. Alrighty. And here you go.
Okay. For our registered facilities, in the next month, before the end of April, we're going to ask that you develop your team and have that first meeting. I know it's not a whole lot of time, but do what you can. And that first meeting, you're going to go to the Interact website, so somebody's going to have to bring a computer or gather around a computer, look at that website, move around inside it, and also to present this project to leadership in any way you can, whether it's going to MedExec, if there's no MedExec, grabbing your medical director as she walks through the facility and telling her about it, talking about it to anyone who's got any clout and getting them on board. And they should be. It's not going to be the first time they've heard of Interact. It's a big buzz in acute care now. As you probably know, as you work with acute care hospitals, they're looking for skilled nursing facilities that have implemented this program, so they'll have heard about it. Talk it up to your colleagues, talk about it with them, show them anything that you find interesting on the website. And if you're a member of a community coalition, like Middlesex or Yale, be sure to let those folks know that you're participating in the Interact webinars and you're on this journey and you're going to implement Interact, because that's important. Inspiring to other facilities as well. And it's important that communities know that about you and your commitment to this work. So, okay, by the time we meet again in April, you'll have a team. Hopefully you'll have that first meeting and gone to the Interact website and have presented this project to leadership, to medical directors, to your administrators, the administrator's not on yet, to your corporate parent, talked about it with your colleagues. And if you're a member of a community, let your community know. And that's it. So thank you so much. We're so happy you're here. We're here for you in any way, to support you in any way we can, and you're going to be part of something special. So thank you.
Next month. So see you next month. Thanks, everyone. I just had a few last-minute announcements before people drop off the call. When we close out of the webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow morning with a link to the evaluation. And again, as I mentioned, the link to the event page on our website. Also, as I mentioned, the PowerPoint presentation is already on our website. The link is in chat. And within a few business days, the recording and the transcript will also be added. Be on the lookout for emails about our next Interact webinar in April. Thanks again, everyone, for attending. Thanks to Sheila, Florence, and Carol, and I hope everyone has a great day. Thanks. Bye.
The router has disconnected. The conference will be terminated in 5 minutes.